There is a pill sitting in millions of American medicine cabinets right now. It costs about $4 and nobody needs a prescription to buy it. And it may be quietly working against the part of your brain that stores memories. If you have ever taken something to help you fall asleep, this matters to you. Because the fog people blame on aging is not always aging at all. Sometimes it has a name, a dosage, and a refill date. Before we get into it, if you are new here, consider subscribing. This channel helps adults over 50 understand their health through practical, evidence-based education. Turn on notifications so the next one reaches you when it goes live. Today, I am counting down 9 medications most closely linked to memory problems in older adults. We start with the ones almost nobody questions and end with the biggest of all. Pay close attention to number 3. It is prescribed to millions of people who believe they chose the gentle modern option. And number 1 is not a single pill at all. It is a pattern, and once you see it, you cannot unsee it. One more thing first, and this matters more than anything else I will say. Nothing in this video is a reason to stop a medication on your own. Stopping some of these suddenly is genuinely dangerous. This is information to bring to your doctor, not to act on alone. Tell me in the comments how many prescriptions you take every day. I read them, and your answers shape what I cover next. Let's start at number 9, and do not let the low position fool you. Number 9 is diphenhydramine, the active ingredient in Benadryl. It is the little pink pill people reach for to sleep or calm an allergy. It sits on an open shelf, costs almost nothing, and needs no prescription. Most people assume that means it is gentle. Inside the brain, it is not. Diphenhydramine belongs to a group of drugs called anticholinergics. That long word describes a simple action. They block a brain chemical called acetylcholine. Acetylcholine is the messenger your brain uses to form new memories and stay alert. Here is the part that changes everything after 60. Your brain naturally produces less acetylcholine as you age, so it leans harder on every bit it has left. A drug that blocks it lands far heavier on a 70-year-old brain than a 30-year-old one. The area that absorbs the impact is the hippocampus. That is the small, seahorse-shaped structure where new memories are formed. The research on this is not thin, and it is not new. In 2015, JAMA Internal Medicine followed more than 3,000 adults, 65 and older. Those with the heaviest cumulative anticholinergic use had roughly 50% higher dementia risk. A much larger British analysis in 2019 found a very similar pattern. This is why the American Geriatric Society Beers criteria lists older antihistamines. It is a formal catalog of medications older adults should generally avoid. Here is your practical takeaway for tonight. Read the label on anything you take to help you sleep. Anything marked PM, nighttime, or nighttime allergy relief is very often diphenhydramine in disguise. Myth: over-the-counter means safe for your brain. Fact: it only means safe enough to sell without a conversation. For allergies, newer options like loratadine or cetirizine barely cross into brain tissue. For sleep, the strongest evidence supports cognitive behavioral therapy for insomnia. It outperforms sleeping pills over the long term with no cognitive cost at all. That is number 9. Number 8 is one your stomach loves, and it deserves an honest hearing. Number 8 is the proton pump inhibitors. The familiar names are omeprazole, sold as Prilosec, and esomeprazole, sold as Nexium. They shut down acid production and get handed out for heartburn and reflux. People stay on them for years because symptoms come roaring back the moment they stop. So the drug feels like the only thing holding the line. Now let me give you the honest version of this science. You may have seen headlines linking these drugs directly to dementia. That came largely from a 2016 study in JAMA Neurology. It reviewed more than 70,000 German adults aged 75 and older. It found a 44% higher dementia rate among regular users. But here is what those headlines almost always left out. Several large studies since then have failed to reproduce that finding. The dementia link is genuinely unsettled, and I will not overstate it to you. What is not unsettled is what these drugs do to your nutrients. Your stomach needs acid to pull certain nutrients out of your food. Chief among them is vitamin B12, which protects the wiring of your nerves. Turn the acid down far enough, long enough, and your B12 quietly drops. Magnesium absorption can fall as well, and both matter for clear thinking. Here's the surprising part most people never hear. A true B12 deficiency can look almost exactly like early dementia. Memory slips, confusion, low mood, tingling in the hands and feet. And unlike dementia, it often improves once the deficiency is corrected. That is the practical point I want you carrying with you. If you have taken a PPI daily for over a year, ask for a B12 level. It is an inexpensive blood test that far too few people ever get. Ask whether stepping down to an H2 blocker like famotidine makes sense. And ask about the simple things that reduce reflux without any pill at all. Raising the head of your bed, finishing dinner 3 hours before lying down, and losing even a modest amount of weight around the middle. The goal is the lowest dose for the shortest time, not a lifetime habit. Quick pause, because this connects to something worth mentioning once. If you like having this kind of information organized in one place, I created the After 50 Health Savings Protocol, a 400-page illustrated digital guide. It covers 28 important health topics after age 50 in one organized system. Understanding your numbers, preparing for appointments, organizing medications, evaluating supplements more confidently. It includes the first-week health organization plan and the health expense tracker, plus the doctor visit preparation workbook, the smart grocery guide, and the supplement decision checklist, plus lifetime access to everything inside. By avoiding unnecessary purchases and duplicate supplements, many readers may potentially save $4,000 to $6,000. The link is in the description below. Now back to the countdown. Number 7 is prescribed for something most people would rather not discuss. Number 7 is oxybutynin, sold as Detropan, for overactive bladder. It is given to seniors dealing with sudden, urgent trips to the bathroom. The relief is real, and so is the dignity it protects. I want to be fair about that before I say anything else. But oxybutynin works by blocking acetylcholine, the same messenger diphenhydramine blocks. And this one crosses into brain tissue unusually easily. It parks itself exactly where new memories are formed. That makes it one of the heavier hitters on this list for an older adult. In 2019, a British analysis reviewed nearly 300,000 patient records. Strong anticholinergic bladder drugs carried among the highest dementia associations in that data. And here is what troubles me most about this particular one. Almost nobody taking it was told any of this at the pharmacy counter. They were told a pill would calm the bladder. Nobody mentioned it might also be dimming the mind. So the fog gets blamed on age. Missed appointments, keys lost 10 times a day, the thread of a conversation dropped. Everyone nods and says, well, we are all getting older. Here is the good news, and it is completely real. You do not have to choose between your bladder and your brain. Mirabegron, sold as Mirabetrip, works through a completely different pathway. It does not block acetylcholine at all. There is also a newer option called Vibegron that works in a similar way. And pelvic floor training with a specialist physical therapist genuinely works for many people. It is unglamorous. It takes about 12 weeks, and it costs your brain nothing. Bring all 3 of those options to your next appointment. Number 6 is one that almost nobody thinks of as a brain drug. Number 6 is the older muscle relaxants. Cyclobenzaprine, sold as Flexeril, along with methocarbamol and carisoprodol. They get prescribed for back spasms, neck pain, and stiffness after an injury. They feel harmless because the problem they treat is a muscle, not a mood. But cyclobenzaprine is chemically a close cousin of amitriptyline. You will meet that one at number 4, and the family resemblance matters. It carries real anticholinergic activity along with heavy sedation, which is exactly why muscle relaxants sit on the Beers list for older adults. The stated concerns are confusion, sedation, and falls. Now let me address the medication you were probably expecting in this slot: statins, Lipitor, Zocor, and the rest of them. You have almost certainly seen a headline claiming they erase your memory. Here is the myth versus the fact, and it may genuinely surprise you. The FDA did add a cognitive warning to statin labels back in 2012, but the large studies since then have not supported it. A 6-year Australian study published in 2021 found no faster cognitive decline in statin users. Broad reviews since have found no increased dementia risk at all. A small number of people do report reversible fog on a statin. If that is you, it is worth a real conversation about dose or switching. But please do not stop a statin because of a video, including this one. For most people, it is protecting a heart and preventing a stroke. Now back to muscle relaxants and what to do instead. For sudden back pain, the evidence favors staying gently active over lying still. Heat, targeted physical therapy, and topical anti-inflammatory gels help many people. Topical treatments barely enter the bloodstream, and that is precisely the point. And when a relaxant is truly needed, a short course beats a standing prescription. Let's pause here for a second. If this is connecting dots for you, tap that like button. It genuinely helps this reach more people who need to hear it. And share it with the person you thought of during that last section. Then tell me in the comments, which one has surprised you most so far? I read every single reply. Now to number 5, and this is where we need to be careful together. Number 5 is the benzodiazepines. Lorazepam sold as Ativan, diazepam as Valium, alprazolam as Xanax. They are prescribed for anxiety, panic, and stubborn insomnia. They work by boosting GABA, the brain's natural braking system. At first, they can feel like a rescue. The panic eases, the racing thoughts slow, and sleep finally arrives. Over months and years, that picture begins to change. In 2014, the British Medical Journal published a large Canadian study. People who had used benzodiazepines for longer than 3 months. They showed roughly 50% higher odds of an Alzheimer's diagnosis. The longer-acting ones like diazepam looked worse than the shorter-acting options. Now here is an honest caveat that most videos skip entirely. Researchers still debate how much of this is cause and how much is timing. Anxiety and insomnia can themselves be early symptoms of dementia, which means some people receive these drugs because decline had already quietly begun. What is not debated is the day-to-day effect on an older brain. These drugs slow learning, blunt mental flexibility, and raise fall risk substantially. Many people describe emotional flatness, as if watching their own life through glass. And the exit is the cruelest part of all. Stop one abruptly, and anxiety and insomnia return with even greater intensity. Withdrawal can include agitation and seizures, and it can be life-threatening. So let me be as clear as I possibly can be here. If you have taken one for more than a few weeks, do not stop suddenly. Work with your doctor on a gradual taper over weeks or even months. There are gentler paths forward. Buspirone can ease anxiety without heavy sedation. Cognitive behavioral therapy for insomnia has the strongest long-term evidence we have, and it is now available through structured programs, not only in-person visits. Number 4 is one medication prescribed for 3 completely different problems. Number 4 is amitriptyline, sold as Elavil. It is an older antidepressant still widely used for nerve pain, sleep, and migraines. That versatility is exactly why it spread so far and stayed so long. It looks like a medication that can quietly do everything at once. Underneath, it is one of the most strongly anticholinergic drugs still in common use. It blocks acetylcholine so aggressively that with long-term use, the math shifts. Memory trouble stops being a rare side effect and starts looking like an expected one. Remember that 2015 JAMA Internal Medicine study from number 9? Amitriptyline was one of the exact drugs driving its highest exposure group. And here's the part that catches people off guard. It does not require a large dose to matter. A small nightly 10 or 25 milligram tablet, taken for years, adds up. People were given it for sleep or for nerve pain. Then they noticed words going missing and concentration thinning out. And they assumed it was simply part of getting older. If someone you love takes amitriptyline, that is a conversation worth having soon. For nerve pain, duloxetine and gabapentin can offer similar relief. Neither carries the same anticholinergic burden, though gabapentin has its own sedation. For migraine prevention, there are newer preventive options genuinely worth asking about. For sleep, start with morning light exposure and a consistent wake-up time. Those 2 habits sound almost too simple to make a difference. They are also among the most reliable sleep interventions we have for older adults. And for mood, sertraline and escitalopram are considered far gentler on the brain. Number 3 is the one I asked you to watch for. Number 3 is paroxetine, sold as Paxil. It is one of the most widely prescribed antidepressants in the SSRI family, used for depression, anxiety, panic, and social anxiety. On the surface, it looks like the modern, gentle, sensible choice, far kinder than the older psychiatric medications it was designed to replace. Here's the detail almost nobody taking it is ever told. Paroxetine is the one SSRI with meaningful anticholinergic activity. That single feature separates it from close relatives like sertraline and escitalopram. It touches the same acetylcholine system every other drug on this list has been disrupting. This is not a fringe opinion or an internet headline. The American Geriatric Society placed paroxetine on the Beers list. Their stated reasoning includes exactly this anticholinergic profile plus sedation. There is a painful irony sitting inside that. A medication prescribed to steady the mind may, over years, work against the very clarity it was meant to protect. Paroxetine also has one of the hardest discontinuation profiles of any SSRI. Its short half-life means even missed doses can trigger real withdrawal symptoms, which is one more reason this is a doctor conversation, never a solo decision. The practical step here is genuinely simple. If you are over 65 and taking paroxetine, ask why this one specifically. Ask whether sertraline or escitalopram would serve the same purpose more safely. Ask for a B12 level 2, since low B12 worsens both mood and memory. For many people, a careful switch is straightforward, and the fog gradually lifts. Before we get to the last two, do me one small favor. Send this to someone who keeps a full medicine cabinet. That single share may be the most useful thing you do today. And drop a comment with the medication that made you pause. Your comment often becomes the reason a stranger asks a better question. Number 2 concerns me more deeply than anything else on this list. Number 2 is the antipsychotic medications. Quetiapine sold as Seroquel, risperidone as Risperdal, olanzapine as Zyprexa. What troubles me is how many people never knowingly agreed to an antipsychotic. These drugs were developed and approved for serious psychiatric conditions, schizophrenia and bipolar disorder, where they can be genuinely life-changing. But today, they are frequently prescribed off-label to older adults for insomnia, restlessness, or the agitation that comes with dementia itself. Powerful medications built for severe illness, now used in homes and care facilities. For seniors who are simply confused, restless, or difficult for busy staff to manage. This is not a small concern buried in an academic journal. The FDA placed a boxed warning on these drugs. It cites an increased risk of death in older adults with dementia-related psychosis. A boxed warning is the strongest safety alert the FDA issues. Beyond that, research links them to higher rates of stroke and pneumonia. Also falls, fractures, and the deep sedation that lands people in hospitals. They work partly by dampening dopamine in the brain. Dopamine drives not only mood, but focus, planning, and motivation. Reduce it enough, and the whole system becomes slower and less responsive, which is why some people on these drugs appear flat, dull, or almost absent, while their families quietly grieve someone who is still physically right there. If you or a loved one takes one, ask one direct question. Why was this started? And is it still truly necessary today? Many behavioral symptoms improve without medication at all. Consistent daily routines, less noise and overstimulation, and better light during the day. Treating hidden pain, which is one of the most overlooked causes of agitation. Checking for a urinary infection, which causes sudden confusion in older adults surprisingly often. When medication is genuinely needed, the lowest dose for the shortest time reduces harm. But families deserve to be told clearly what they are agreeing to. Now we arrive at number 1. And number 1 is not a single medication at all. Number 1 is the combined anticholinergic burden of everything you take together. You were probably expecting one final villain, one single worst pill. The reality is quieter and far more common than that. The greatest danger usually comes from several mild anticholinergic drugs stacking up, while nobody, anywhere, ever adds up the total. Polypharmacy simply means taking many medications at the same time. Anticholinergic burden is the combined weight of all of them. Blocking the same memory chemical, in the same brain, on the same day. Picture a completely ordinary situation. Someone takes a nighttime allergy pill to fall asleep, oxybutynin during the day for bladder control, and a low dose of amitriptyline for nerve pain in the feet. Individually, each one might barely register as a problem. Together, the effect compounds and the burden climbs fast. And this is not theoretical in the slightest. That 2019 British analysis I mentioned reviewed nearly 300,000 people. The heaviest cumulative anticholinergic exposure carried close to 50% higher dementia odds. The pattern was dose-dependent. More burden, more risk, every step of the way. And the overwhelming majority of those patients had no idea. They did not know they were taking anticholinergic medications at all. Nobody had ever explained the category to them in plain language. Here's the part that made me want to make this video. Cognitive symptoms driven by medication burden often improve when that burden comes down. This is fundamentally different from Alzheimer's disease in one crucial way. Deprescribing studies show many people regain clarity and alertness within weeks. The brain is more resilient than most people assume once the pressure is removed. And the solution does not require anything exotic or expensive. It requires one appointment that most people never think to book. A full medication review with your doctor or your pharmacist. Bring everything. Every prescription, every over-the-counter product, every supplement. Bring the actual bottles, not a list from memory. That detail matters more than you think. Ask one sentence. Can we add up my total anticholinergic burden? Scoring tools exist, pharmacists know them, and the review is often free. Then, unnecessary medications can be reduced or stopped under proper supervision. Safer alternatives can be introduced, and your brain gets a real chance to recover. This may be the most preventable threat to the aging brain on this entire list. And that is exactly why it holds the #1 position. Thank you for staying with me through all 9 of these. I know that was a lot, so here's what I hope you take away. You are not powerless here, and you are not imagining the fog. You are allowed to ask why you take every single thing you take. If this was useful, subscribe and turn on notifications so the next one finds you. Give it a like and share it with someone who deserves a better appointment. And leave a comment telling me what you want covered next. I genuinely build future videos around those replies. And if you want to go further than one, video can take you. The complete After 50 Health Savings Protocol is linked in the description below. It is a 400-page illustrated guide across 28 key health topics after 50. You also get the first week health organization plan and the health expense tracker, plus the doctor visit preparation workbook and the smart grocery guide after 50, plus the supplement decision checklist and lifetime access to everything inside. It exists for one reason, to help you walk into appointments informed and organized, more confident, better prepared, and clearer about every everyday health decision. And by avoiding unnecessary purchases, duplicate supplements, and poorly planned visits. Many readers may potentially save $4,000 to $6,000 over the years. Investing in knowledge today is what makes tomorrow's decisions calmer and more confident. One last thing before you go. Your medicine cabinet is one place your body keeps its warnings. Your hands are another one entirely. Your fingernails can show signs involving circulation, nutrition, and thyroid function, sometimes long before anything else gets noticed at all. That is the next video, and I will show you exactly what to look for. Until then, stay curious, ask good questions, and take good care of yourself.